All right, welcome. This is introduction into violence and suicide. Like the last video that I just recorded just a second ago and have posted. The reason why I'm going into suicide is because of its relevance and sort of the scary increasing of rates, and the fact that so many people who they've noted that when they've gone back and looked at people who have completed suicide, that they've seen that. So many of them visited a healthcare environment, even if it wasn't psych specific in some capacity. So, preparing and allowing us all to have these tools to be able to work with somebody who's suicidal or to screen appropriately somebody who, even if not in that setting, can certainly save lives. Okay, so I have a couple resources. The Thomas Joyner, who's probably my favorite psychologist on this topic, a suicidologist. His videos are fabulous. He has more online that I recommend. He has books that I recommend. The content is sometimes hard to get through, but it's fabulous. And I really his psychology makes sense to me in my experience of working with people who are suicidal. And so I'll kind of review it a little bit. He does as well in more details, but I'll try to pick out some things that are higher yield. However, I might get a couple of test questions from his video alone because I certainly want you guys to watch it. It's so important. Um, Talk about some myths and some thoughts that people have with suicide. I also posted one of his articles on the myths of suicide, and I also posted an article about how to talk about suicide with somebody that maximizes their willingness to disclose, right? And I talked to a patient the other day, and he says, you know how many times I've told somebody I'm not suicidal just so I can discharge from a hospital, right? And for a lot of people, suicidality is constant and chronic, right? And it does not go away. It does not mean we need to send them to the ER. Sometimes I even tell patients, they're like, we almost went to the hospital this week. I was like, well, go to the hospital and sit in the ER for 8 hours, and then you'll start feeling really suicidal, right? Not a lot of resources for people, and so if we can work with these people, not these people, but you work with people in general who are having these issues where they're at, and a lot of times you can avoid hospitalizations, and you can kind of work with it because suicidal thoughts are really common. I mean, a lot of people have them, more than people probably maybe understand, but most people can identify with the thought of some capacity, and and so we'll talk a little bit about how to identify somebody who's at risk, who has suicidal thoughts, or somebody who's at risk for completing. And I'll try to come up with some examples. Okay. So some of the myths that you'll see in that article is that the idea, the framework that somebody comes to, the psychological when, and I'm talking about somebody who completes a suicide, and it's important to use that language too. Okay, suicide, you cannot fail suicide attempt, and you cannot succeed in a fail. Those are good and bad terms in the sense that, congratulations, you succeeded, or it's too bad that you failed, right? Very stigmatizing word. So I like to say, I like to use the word complete, or sometimes you can just say suiciding. Completing a suicide is probably better. Joyner will refer to people who died by suicide as uh, um, suicide decedents. Okay. The or people who lost loved ones. Okay. And so using that language of completed suicide and suicide attempt, not a failed suicide attempt, right? A suicide attempt. Um, so the mind frame here, and Joyner really pushes the fact that it's not selfish in a sense that the idea is that um, everyone's life would be better off with if I wasn't here anymore. That's the ultimate mind frame of I'm a burden and I will improve their life if I die. And so therefore it's not this vengeance killing, the vengeance suicide, right? I've seen some attempts. I've seen some suicidality that seems very vengeful, but those aren't necessarily the kinds that tend to lead to completions. Okay, maybe some of them are, but really, the vast majority is that the opinion is that my everyone's life would be better off without me. Okay, and I've talked to people and I've tried to intellectually appeal, like, hey, you have kids, and they say, well, it would be hard at first. That's what they say. But I know that after they're able to get over it, their lives would be better, right? Which is absolutely wrong, right? Which is completely wrong. We see the devastation that suicide leaves, and it is catastrophic, and it is almost contagious in the sense that then other people potentially become high risk for suicide, right? We know that isn't the truth at all, right? Even for people who, you know, may be a burden ultimately. So it comes down to these three big risk factors. Okay, there's this perceived burdensomeness. Okay, and there's so many risk factors, hundreds of risk factors for suicide, and these are Joiner's top three. Okay, perceived burdensomeness, right? The idea that people's lives would be better off without me. Okay. Um, the next one is thwarted isolation, thwarted belongingness, which really just means isolation or aloneness, right? There's no one. The community is so important, and without it, okay, even if it's perceived, and this is not always accurate. Like I feel so alone. I was like, well, this person in your life. It doesn't matter. It's their perception, okay? And the burdensomeness may be real or perceived as well, right? They could be very, a lot of times with the repeated suicide attempts and suicide hospitalizations and the fear that everybody has that you're going to kill yourself is burdensome, right? It is burdensome. So there might be some accuracy there. Okay. But the burdensomeness, the isolation, and then the last one, which is literally the ability to kill oneself, right? And Joyner calls it fearlessness, right? It's not bravery, it's fearlessness. And the video goes into probably the video itself is mostly about fearlessness. So I don't need to go into much detail about that. But it's that final piece has to be there in order for the suicide to happen. And a lot of times it takes years and years and years for it to get to that point, right? And that's why the mistake of saying, well, if he would have killed himself now, based on how many times he brought it up. Right? They're always saying he's going to kill himself, and if he was going to do it, he would have done it. And that's absolutely wrong, because somebody can go 20 or 30 years talking about it, and then at some point complete, right? And it's the building the fearlessness, right? It's almost like a desensitization that it takes by just thinking about it. And the idea is that when they have that and they're in that place in their head, right? It's a tunnel vision. And now all of a sudden there isn't another option. Okay? There isn't another option where suicide is going to happen in their head. It's that resolve, the absolute resolve. Okay? And while they're building a resolve, here's a couple more really high yield symptoms that can occur that tell us that something could be happening. Incredible weight loss and loss of appetite within a week or two, just drops. Okay, agitation, but somebody, if you ever get stuck on a problem and you can't do something until you solve the problem. That's kind of what suicidality is they ruminate it, and they talk about people who've done this will pace. They'll go outside and just pace and pace and pace, and someone will come up to them and say, hey, what's going on? And they'll completely ignore, just complete just in their head agitation, trying to get that resolve. How am I going to solve this problem? Which tends to lead to suicide. Okay, insomnia, sleeplessness, right? There's they're just not sleeping, and then that can play incredible tricks on your brain. And your brain. I was listening to an interview talking about Robin Williams' suicide, and he says his brain was giving him false information. Well, when you go sleeplessness, your brain will tell you the craziest stuff. And I talked to somebody who attempted suicide in a very lethal way, and she said, I looked at the pills, and they were sleeping pills, and I just wanted to go to sleep. I hadn't slept in days. Okay. A very lethal attempt. Did not die, but that's what I told their guardian. I said the amount of pills they took and the certain medication they took was very lethal, right? And so it's a miracle that they're with us. I think that in that case. So agitation, nightmares. These humans are having dreams about suicide. I work with a lot of people who have chronic nightmares, but I still consider it a risk factor. Okay, a lot of times in my treatment, I'm treating nightmares right away. Okay, I'm not waiting. I can usually treat nightmares pretty quickly. A lot of times depression takes a while to treat. But the nightmares is another one of those cute ones. And isolation, right? Going off on their own, right? Those are your really there's other than the hopelessness, not the hopelessness, the perceived burdensomeness, the thwarted belongingness, and the fearlessness, the tear down, and these are the symptoms that can happen right before agitation, the sleeplessness, the appetite loss and weight loss, the nightmares, and the isolation are big clues that something's happening, right? That probably the conversation is worth having with them. Okay. Other huge risk factors: mental health conditions of any kind. Substance abuse is pretty severe. But what Joyner will talk about is that most people who complete are sober. I've definitely seen a lot of attempts with somebody who's not sober. But what he talks about is the act itself is complicated enough that the person can't do it when they're not sober. Okay. And so when you look at the graphs, sure, there are certainly some people who are able to who do complete suicide while inebriated to some capacity. But the more inebriated they are, the very less likely they're able to do it. Okay. And so a lot of times what you'll see is somebody who's a chronic alcoholic for decades and then stops drinking for 2 weeks. Okay, and then they'll commit suicide. And you can see how that, as a family member, might feel relieving, right? They're finally sober, right? Finally sober. And so, sobriety after a couple of years is certainly protective, but that sobriety right away, that was any change, any abrupt change it makes you think, right? Depression is certainly what we attribute to suicidality the most, and I've had this conversation with other colleagues of mine that I don't think it's the only one. And I've seen depression. A lot of people think depression creates suicidality, which, like we said, it's not. It's the burdensomeness and the isolation. But depression is certainly a risk factor for it. But I've certainly seen people who are suicidal who are not depressed. And I've seen people whose depression and suicidality resolve independently of each other, right? Oh, the less depressed you are, the less suicidal you are. Not necessarily, right? I've talked to people who are not depressed anymore, but they still want to kill themselves. Or people who are still incredibly depressed, but for the first time in decades haven't wanted to kill themselves, okay? I've talked to both of them. And a lot of times anxiety, okay, anxiety is a big risk factor, probably maybe even more necessarily, right? Depression, the person tends to, the melancholic depression where they lose a lot of energy. They may have the suicidal thoughts, they may not have the energy to do it. But anxiety can be tormenting, right? This term called akathisia that you guys might get, where there's this idea of this internal restlessness that a lot of the psychotropic medications we give is a huge risk factor for suicidality, right? If they feel restless, they can't sit still, they're pacing, right? That kind of agitation may not be psychosocial or emotional or psychological agitation. It might be physical agitation, and we call that akathisia, the idea that they can't sit still. Right. You can go on YouTube videos and look at my videos of akathisia, and you'll see that it's absolutely tormenting. PTSD is certainly a huge risk factor, and PTSD is usually where you get your nightmares, right? A lot of people who have nightmares are having it because of the trauma they've experienced, and that puts them at a significant risk, like we talked about. And bipolar disorder, and I meant to double check this, and so my statistics may be a little off, but they kind of vary based on what source, but it's pretty consistent. That bipolar disorder, the risk of suicide in somebody who has bipolar is 20%, 1 in 5, which is mind-blowing to me. It might be 25%. I should have checked. Sorry. It's very, very high. It is it's hard to hear, right? And we think of bipolar as depression and then mania, right? But really a small percentage of people have these concrete depressive episodes with these concrete manic episodes. Most of the people who have the illness are in here, and we call that mixed, right? Where you have energy, but you're depressed, which is this combination that makes it very lethal for suicide, right? I'm sad, I'm alone, I'm isolated, no one cares about me, but I have all of this energy, and I'm agitated and angry, right? That's what we call mixed states. And mixed state is the highest risk. Psychological condition, psychiatric condition, the highest risk for suicide, certainly, a mixed state. And you can have mixed states of people with just depression and bipolar, okay? There is a continuum of suicidality, which I think is important to sort of acknowledge. Okay, and I'll talk to some of these people who are just kind of really into the macabre, really into death and dying, and they're not necessarily suicidal, but they think about funerals, and maybe they like movies about it, right? They're really focused on this death and dying. They're almost like an obsession to them, even though they're not necessarily thinking about them dying. Okay, that's kind of on the scale, and then it kind of builds up. You have this passive suicidality. Okay, the idea that I would be better off dead, and people's lives would be better off without me. But there's no actual I want to die. I want to kill myself tomorrow, right? There's not this active component to it. It's passive, right? And you can assess for this passive suicidality by asking questions like, have you ever thought about wanting to go to sleep and never waking up, right? These and so that's what the passive suicide. I'd rather be dead, right? But it's not that I want to kill myself. Then you have active suicidal thoughts with no plan, okay? And then you have active suicidal thoughts with a plan, right? And then as it goes up, then you have a suicidal attempt, but the plan was fairly non-lethal, right? Overdosing on Tylenol. And what I always say is, ask the person if they said that they wanted to die, then it was a suicide attempt. Even if I think one person recently told me they overdosed on like toothpaste or something like that, and they really were adamant that it was an attempt, and you take them, you believe them, you chart it as an attempt. We did the whole paperwork that it was a suicide attempt, even though it was certainly not lethal. Okay, and then you have lethal attempters, and then you have suicide completers. Okay, and that's the continuum of it. somewhere in there, self-harm will go. Non-suicidal self-injurious behavior is what's called NSSBI. There's also self-injurious behavior. No, NSSIB. Sorry. And then there's self-injurious behavior, which sometimes people aren't really sure if it's suicidal or not. You can ask them, and they say, "Did you cut yourself? Did you want to die?" And they said, "Yeah," but it could be passive mixed with SIB. Can be hard to distinguish. But some people just have non-suicidal self-injurious behavior. A lot of people, not a lot of people, but I see a lot of people with it. And they don't want to die. They're not suicidal. The cutting or the hurting themselves in some way, the burning or whatever it is, it creates like an endorphin rush for them. It can be addictive, right? And we even treat it with anti-addictive medications like naltrexone, which is an opioid binder, telling us, and it works for a lot of people, so telling us that cutting actually releases an opioid response, right? Which is probably hugely self-medicating for these individuals. They don't want to die. They're not suicidal. And what the risk is that if it's truly non-suicidal, it isn't necessarily a risk factor for suicide completions. It's the data is mixed. The studies haven't been clear, right? So it's certainly nothing that to say, well, they're not, they're you shouldn't never, they certainly take it seriously. But I think that when somebody is suicidal and they're self-harming, it is an increased risk because it plays a part of that desensitization, right? I have had people tell me I'm cutting and I wanted to see how far I could cut, and they cut deeper and deeper every time. Okay. And so that's kind of the differentiation there. So self-injurious behavior, as far as we're concerned, is a risk factor. But there are some research articles that shows people who self-harm without the suicidal thoughts probably are not any more at risk than anybody else because the self-harm is not itself suicidal. But for people who are suicidal, the self-harm is a more of a inoculation to the idea of killing themselves. Okay. I should have. I'm trying to think of other things that I think are important in high yield. I have a lot of resources for you. The listeners that we're going to watch next week is a great example of language to use when you're doing an assessment. You have to say suicide or kill yourself. Do you have any thoughts you want to kill yourself? Do you have any thoughts of suicide? If they don't know what the word suicide means, or that's not in their vocabulary, you have to say kill yourself. Okay. Do not say harm yourself. Okay. Like we talked about before, some people want to harm themselves, but they do not want to die. Okay. And some people really want to die, but they do not want to hurt themselves. That is the whole point. They're in too much psychological pain. They want the pain to end. Do you want to hurt yourself? God, no. I want the pain to end. Okay? You cannot use hurt yourself. You have to use kill yourself. And then you can go on to assess self-injurious behavior, okay, independently. And so what I really recommend, especially if you're in a setting or if you identify a risk of suicide or think there's suicide there, ask them if they have any thoughts to kill themselves. Ask them a passive suicidality question. If you ever thoughts that you'd rather go to sleep and never wake up, kind of a passive suicidality question, and then ask them if they have any self-harm thoughts. Okay, it's important to ask all three, I think, in my opinion. But the listeners talk about language, and it's so incredible the language they use. One of the things he says in the very beginning of it, he says, even the fact that you're talking to me about this tells me that there's a part of you that wants to live. It's such a heavy statement. It's so good. The fact that you're telling me you're feeling suicidal tells me there's a part of you that wants help. Okay, that tells me there's something in you that wants help, and I want to give you the help. Okay, that language is absolutely fabulous. And here's the deal: why don't we ask about suicidality? It's the same reason why we don't ask about abuse, right? Because what do they say? Yes, right? How scary is that? Oh, right. What do we do when a kid tells us they're getting abused, right? What do we do when a kid tells us they want to kill themselves? Right? How do you react to that? And so I want you guys to feel comfortable with that. Right? I want you guys to be comfortable when someone says yes, what to do for both of those questions, really. But I know you're going to go in more detail in the psychiatric class, and so I want you guys to be the goal where if someone says yes, I'm feeling suicidal, because that's the difference between you sitting in the ER with a new intake with your back turned to them typing away, and you're saying you're not feeling suicidal, right? And they're like, no, and you move on, right? You ask it that way because you don't want them to say yes. You're not giving them permission to say yes. And the difference is then you turning to them, you stop typing. Even if it's a moment, if they're right here, I'm open to them. Even if it's for a moment of openness. Even if I'm just going to give them 10 seconds because I got to get this note done too. You got somebody down the hall. I'm not spending 3 hours after my day charting. So I'm going to finish charting in the session. However, I'm going to spend 10 seconds to be open to you to tell you that you can say yes. Are you having any thoughts that you want to kill yourself? Right? And then they pause. No, I'm not. Okay, go back. No. They paused. Say, I noticed you paused there. You were uncertain for some reason. Let them tell you yes if the answer is yes. Okay? Let them tell you yes. If you're in a psychiatric, if you're in the ER, you can keep them safe, right? And so If you guys see that, if I see that in discussion boards, if you guys want more, I could record more videos about how to intervene there. Some intervention ideas I have, things that I've seen is that people who feel suicidal, especially kiddos, and their parents know it. Their parents are ride them about it. They ride, I mean, they're like, are you okay, honey? Honey, you have to talk to me. Honey, you have to talk to me. You have to talk to us, honey. You got to talk to us. What are you telling them when you do that, right? You are telling them you are a burden to us, right? It feeds the burdensomeness, right? And so, and then if they know every time they go downstairs to the kitchen and you're down there and like, honey, how you feeling today, right? Are you still feeling the same way? Are you still feeling the same way, right? If they know that there's not going to be an interaction with a parent that is not going to be about it, they're going to avoid the conversations, okay? And so this is what I'll tell parents to do, especially since after it's been like this for months, right? Is you have to create a norm where most of the interactions are not about it, right? As a matter of fact, I would even schedule a time, not very often, maybe at most once a week, if preferably less, once every other week, where you can check in for 10 minutes. That's only one time. Every other time is about something else. Even if it's about nothing, have a 5-minute conversation about the weather. Go sit in their room while they play in their game and just sit there and not ask them about. You got to condition each other. This is for the parent and the child. Condition each other that every interaction is not going to be about the person's mental health, right? Because it's going to make it exhausting, and it's going to feed that burdensomeness. But at the same time, right? The isolation, you can't let them be isolated. If they're in the room all the time, you got to go check on them. So how do you go between the two? And the intervention, I think, is to make sure that there's time spent with them that isn't about suicide or about the issues. Okay. And that way they know that when you're coming up to them, hey, honey, can we go for a drive? Right? They know what it's about. They don't want to get in the car with you, right? But if you condition each other to know that we're not going to talk about this until it's time, right? And then maybe the kiddo's able to come to you independently and talk about it. Does that make sense? That's an intervention I do all the time. That's really specific for a parent-child, mostly adolescent interaction. But you can hopefully you can kind of pull it apart if it's for an older adult or a spouse or a friend or anything like that. I'm trying to think. Protective factors are huge, right? Identifying protective factors. I tell about an example of a person who will put a picture of their daughter on the mirror as they shave because they get triggered by whatever it is. My answer would be by electric razor or whatever. And so they have to stare at a picture because they will not hurt themselves because they do not want to hurt their kid, right? Use it. Use those protective factors. You told me that last week you went over to a bridge and you stared over the side of it, that you were feeling like you're going to suicide. What stopped you? And it's like, I cannot leave so-and-so. I have too many responsibilities. I know it'll hurt these people. Okay. Use it. Use those protective factors. Some people it's because they don't want to go to hell, right? They're Catholic. Use it. So a lot of people it's their animals. Okay. I don't know anybody who's going to take care of my animals. And like, answer is use it. Hopefully the animal's not that old, right? The animal's aging. Maybe you're asking them, hey, you ever think about getting another puppy, like an overlapping puppy? That's a little dark humor. Sorry about that. But it's true. Use it. Use those things. Okay. I think that's all I can think of for now. I'm not trying to make this redundant for your other classes. I'm not going to talk a lot about how to do a full SRA suicide risk assessment. I'm going to let you guys do that in the other class. But it's the big triggers, when I'm talking to somebody who's looking for those agitation, nightmares, sleeplessness, appetite loss, ask them about if they feel like they're a burden to other people, ask them if they're on their own. I have talked to some people who are absolutely on their own, and it can be really scary when they're suicidal. Okay. Talk to them about attempt history, right? They cut themselves every day and they want to die. It's definitely a risk factor. Okay. Suicide risk means and lethality. I guess I am going to overlap a little bit. Okay, means gunshot is certainly the most deadly. Okay, 95% of gunshot attempts are lethal. What's the next one down from there? Ligature, asphyxiation. 90% of asphyxiation attempts is lethal. So hanging is very lethal. And what we see in countries with high rates like Lithuania is they have a high percentage of hanging, which means that they have a rate of suicide, very high rate of suicide. Men tend to use firearms more, so therefore women are more attempt 4 times as much, but men complete, I don't remember what the ratio is, twice as much, something like that, because they tend to use lethal means. Women tend to use poisoning, like overdosing on drugs. Tend to, by pattern, right? And so assessing means. I want to commit suicide. I'm going to overdose on toothpaste isn't a lethal mean necessarily. If they're in the hospital and their means is to go jump in traffic, they're not going to jump in traffic because they're in the hospital, right? If they're in a lockdown unit, okay? If they're secretive about their plan, then that puts them at high risk. A lot of people go on a one-to-one in the hospital because they won't tell us what they're thinking. I got something. I think I have enough. That's a nice phrase. Yeah, I think I have enough. Have enough of what, right? Maybe they're cheeking their meds. Okay. Lethality is really important. Getting the guns, so if they're in a community, getting the guns out of the house, right? It's hard for some families, hard for some people. But I would say I don't push the permanence. I say, can somebody come to your house and take your guns and put them in there safe? Somebody you trust, right? Can really save someone's life. Okay. Medications in a locked up cabinet, just distributed once a day. It's a great nursing intervention. Sometimes I've recommended 4 times a day, and up to 4 days, right? A weekend's worth. Most medications is not lethal. One patient I had overdosed on a medication on lithium, but they only had 4 days worth. They took a lot of lithium, and the parent felt really bad. But I honestly think that was a successful intervention because they didn't have a whole pill of lithium to take. They just had 4 days worth. And so when they did their lithium level, it was like 1.9. It wasn't toxic. Okay, so they did not take any, not even a toxic level of lithium, and so there wasn't any damage there. So that was a successful intervention, even though they did overdose. There was only 4 days to overdose on. So I think that's all I have for that. I might think of something that I forgot to bring up, but watch the video with Joyner, read those articles, and we'll watch the listeners next week. And based on your discussion board, I'll try to post another round of review and see what you guys talked about. If you have any questions, put them there and or email me them. If you want me to address anything else in another video, if I do one for suicide, I will address it if you email me those questions. Okay. Have an excellent week, and let me know if you have any questions or concerns.